All right, excellent. Well, thank you to the Focal Therapy Society and to Angiodynamics for inviting and coordinating this webinar. I know that Dr. Polascik and I look forward to discussing irreversible electroporation and reviewing results of the PRESERVE trial with this group. And then we also look forward to an engaging discussion with the participants afterwards. So these are our disclosures that I'll leave up for just a second. So today we're going to walk through essentially five main areas. First, what is irreversible electroporation, which we'll just refer to as IRE? What this actually is at a practical level. Second, a representative case to sort of ground this in reality. Through that, we'll discuss the clinical workflow, what this actually looks like in your ASC or in your operating room when you're performing an IRE case. And then following this, I'll hand things over to Dr. Polascik, who will review technical optimization of this approach and also review outcomes from the PRESERVE trial, which is the pivotal US study evaluating IRE in intermediate risk prostate cancer. So most of us are familiar with focal therapy platforms that rely on temperature, either cryoablation that freezes tissue or HIFU that heats tissue. And IRE is fundamentally different. It's a non-thermal ablation modality. Instead of freezing or heating cells, it delivers high voltage, ultra short electrical pulses between needle electrodes placed within the prostate. And these pulses disrupt the cell membrane in a way that leads to cell death without relying primarily on thermal injury. And at the most basic level, electroporation refers to increasing cell membrane permeability using an electric field. And when an adequate electric field is applied across a cell membrane, nanopores form within the lipid bilayer. If the exposure is brief and low enough, essentially if there's an insufficient amount of current that passes through the ablation zone, those pores are going to eventually reseal. This is known as reversible electroporation. But when the electrical parameters produce current within an optimal range through the ablation zone, those pores are going to remain permanently open, and that's what's known as irreversible electroporation. So here's the stepwise sequence. During treatment, high voltage pulses are delivered between electrodes placed around the target lesion in the prostate. Immediately, cell membrane permeability increases and nanometer-sized pores form. Over the course of the next several hours, this disruption leads to an apoptosis-like cell death. Over days, cellular debris in the ablation zone is cleared through phagocytosis. Importantly, the extracellular matrix and connective tissue architecture is relatively preserved, along with microvasculature, lymphatics, and neural structures. And this may help protect critical structures such as neurovascular bundles and the urethra along the urinary tract. So compared to other ablative therapies available, there are some notable differences in approach, mechanism of action, and strengths and limitations. Both cryoablation and IRE are performed via transperineal approach, while HIFU is transrectal, and of course, IRE has a non-thermal mechanism of action. While cryoablation has the strength of real-time ultrasound monitoring of treatment, and HIFU can be advantageous to treat posteriorly located lesions, both are limited by risk of thermal injury to critical GU structures. Additionally, glands that are too large, lesions that are too anterior, and the presence of calcifications may limit which patients are suitable candidates for HIFU. IRE, however, can ablate lesions essentially independent of gland size and has high utility in treating anterior, lateral, and extreme apical lesions. Many of the cases I've done involve treating across the urethra, and I have not observed any urethral toxicity in doing this type of approach. Additionally, with a transperineal approach, there are maneuvers that can be performed or hydrodissection that can also be performed that allows for ablation of more posterior lesions. Cryoablation, as we've discussed, induces hypothermia, resulting in a central necrosis and peripheral apoptosis. HIFU induces hyperthermia, a coagulative necrosis, and resultant protein degeneration and denaturation. Both of these are thermal therapies. IRE, as we've mentioned before, by contrast, does not depend primarily on thermal therapies. While some secondary heat is generated, its mechanism is membrane disruption via those electric fields that we talked about. And this distinction matters most when treating near the urethra or other critical structures where collateral thermal injury is a concern. There's also, as shown on this slide here, interest in the immunologic consequences. Thermal ablation can denature tumor-associated antigens that are released when cells undergo cell death, whereas IRE may preserve antigen integrity. Early studies suggest activation of effector T cells that play a pro-inflammatory and pro-immune stimulatory role, and reduction in regulatory T cells, which play more of an immunosuppressive role following IRE. So patient selection is critical for any focal therapy approach. Ideal candidates include those with life expectancy greater than 10 years, PSA less than or equal to 15, clinically localized disease less than clinical T2C, and Gleason grade group 2 and selected grade group 3 patients. Lesion volume should generally be under 2 mLs on multiparametric MRI. And we also, importantly, need concordance between imaging and biopsy and careful consideration of lesion location and its proximity to critical structures. And so what I'll often describe to patients when I see them in clinic and they're interested in focal therapy is we talk about the story that their imaging describes, where we would expect cancer to be present and where we would expect it not to be present based on presence of MR visible lesions. And then the story that their biopsy pathology describes, essentially where cancer is or is not located on MR fusion targeted biopsy. And these good candidates for focal therapy are going to have similar stories being told on their imaging and on their biopsy. There are other factors to take into consideration beyond standard data points that we commonly use to risk stratify patients with prostate cancer. So we can consider patient factors, comorbidities, their individual values and tolerance for risk, imaging factors for things like tumor volume and location, and biopsy pathology factors for quantification of pattern 4 and presence of histologic variants like cribriform or intraductal patterns. Occasionally, in appropriate circumstances, we will obtain genomic classifier testing with something like a Decipher test. Here we show a figure describing various treatment templates that are used to perform prostate ablations. And at the top, we discuss, or it shows focal therapies. There are quadrant ablations, a couple of different templates for hemiablations, whether you're doing it laterally or anterior or posterior, a hockey stick ablation, and then a subtotal ablation. And when selecting a treatment template, we need to consider both lesion location and size, proximity to critical structures, including the rectum, gland size, and other patient factors as well that may influence treatment approaches that are suitable or not suitable. So we'll transition into a case presentation to sort of bring home what IRE is capable of doing in the clinical setting. So I'd like to share a case of a patient who came to see me in clinic who was ultimately treated with IRE targeted prostate ablation. He's a 72-year-old man with hypertension and good baseline urinary and erectile function. He was initially diagnosed with grade group 1 disease on targeted biopsy of a PIRADS 4 anterior lesion and appropriately elected for an initial course of management with active surveillance. Over the course of the next year, his PSA rose from 6.3 to 9.2, and repeat MRI showed increasing diffusion restriction in the same anterior PIRADS 4 lesion. These here are representative screenshots from his multiparametric MRI. We have T2 weighted imaging on the left and the ADC map on the right. Both show the index lesion of concern at the left anterior transition zone at the midgland. And the radiologists who we work with here truly are experts and they help us out. And they will, on the ADC maps, measure and look at diffusion restriction and let us know if they have suspicions that there's something that's a little bit more aggressive biologically that's occurring that maybe meets the naked eye when reviewing these multiparametric MRIs. So we performed MR ultrasound fusion targeted and systematic prostate biopsy with the following pathology results. This patient's grade group 2 disease is present only within the MR visible lesion, and all other biopsy cores are benign. Our pathologists we work really closely with them. They also help us by giving us quantification of pattern 4, not only as a percentile of the amount of cancer that's present in a given core, but also they calculate the total cancer length and then the total length of tissue that's submitted for biopsy cores as well. This, again, helps with more contemporary risk stratification, knowing that there is evolving evidence to suggest that perhaps different means of quantifying the amount of pattern 4 present in a given biopsy may serve more accurate sort of prognostic roles. So in total, this is a classic example of a really good candidate for focal therapy, specifically for IRE ablation. He has an anterior index lesion with a moderate amount of tumor volume. He has favorable baseline function and quality of life and strongly desires to maintain this. His disease progression occurred while he was on active surveillance, but based on imaging, still has what is apparently organ-confined disease. And given progression over the course of 1 year, he has concerns about remaining on surveillance, and he strongly desires avoiding whole gland approaches like radical prostatectomy or radiation therapy. So the next thing I'll do is I'll talk about the clinical and procedural workflow that we use here to perform IRE. We'll go through each of these not only on this slide, but in subsequent slides to sort of really bring the details home. So before diving into all of those details, we should emphasize the three important safety pillars for the IRE procedure. First is that there must be neuromuscular blockade to prevent muscle contraction during treatment. We're in constant communication with our colleagues in anesthesia to ensure full paralysis of patient, zero twitches prior to starting and delivering treatment. Second is careful electrode placement away from critical structures, and this really underscores the importance of real-time ultrasound to measure distances from probes and distances from the probes to critical structures. And lastly, remaining within appropriate amperage window to ensure that IRE is going to occur within the entire treatment field and to avoid inadvertent thermal damage within the treatment field. So following induction of general anesthesia, we'll place patients in the high lithotomy position. And this is crucial, especially if we're treating anterior lesions like the one that we're treating in this patient, because pubic bone interference may prevent optimal electrode placement. We'll place a Foley catheter in sterile fashion, and then the patient's prepped and draped with an ioband to retract the external genitalia away from the perineum, as shown here. The ultrasound probe is placed on a stepper and a brachytherapy grid is then added. And then lastly, we'll use the Euronav system during these procedures. So the electromagnetic field generator is brought into place and you can see that sort of hovering over the patient there. So once all of the equipment has been set up and the ultrasound image has been optimized, the next step is for me to recreate my MR ultrasound fusion in Euronav. And I've found this to be extremely helpful in electrode placement and optimization of the ablation field. And here we can see we've created a nice fusion that almost perfectly is superimposed over the ultrasound image in both the axial and the sagittal views. Next, I'll move to the sagittal view at midlines where we can see the urethra usually and the catheter. And there I'll measure the full length of the prostate. And we use this information along with lesion size and lesion location within the prostate to determine the amount of tip exposure for the electrodes, which will either be 1.5 centimeters or 2 centimeters, depending on our desired ablation zone. We'll then return to the axial view where we can see the epicenter of our index lesion using the Euronav fusion. And so using coordinates on Euronav and the brachytherapy grid, we can start placing electrodes. And my general strategy here is to start placing my anterior-most electrodes first, especially the electrode closest to the MR visible lesion, to anchor these important electrodes into position. And I'll oftentimes place these electrodes within 2 to 3 millimeters of the capsule and can confirm I'm solidly within the prostate by switching back and forth between the axial and the sagittal views. And as we're placing these electrodes, we're constantly measuring an axial view to ensure that they're appropriately spaced from each other. And ideally, this would be somewhere between 11 millimeters and 22 millimeters distance. But in reality, And we can still obtain a really good ablation zone as long as the electrodes are between somewhere around 8 millimeters to 24 millimeters. But those are sort of at the extreme ends, and we'll likely have better ablation and better zone coverage if we stick in between that 11 to 22 millimeter distance. In the axial view, we also need to keep in mind that the ablation zone will extend 5 millimeters beyond the electrodes in all three dimensions. So the graphic at the top right of the slide here demonstrates how the IRE ablation zone is going to extend beyond the electrodes in the axial view. And so once we're happy with how the electrodes are placed and the distance between the electrodes and the orientation has been optimized, we'll switch back to the sagittal view to confirm we've placed electrodes to the correct depth and the proper needle tip exposure. And here we're sweeping across the prostate back and forth and can see how the electrodes are placed with correct depth and tip exposure. So we can see that they're bracketing the visible lesion on MRI right here, and the tips of the electrodes extend beyond where that visible lesion is on MRI. And remember that the ablation is going to extend 5 millimeters beyond the electrodes in all directions as shown in the graphic on the top right. Importantly, we should confirm that these electrodes are placed parallel to each other and that the tips are all positioned to the same depth, and that tip exposures are the same for each individual electrode that's placed. We can then also measure in the sagittal orientation how far back the ablation zone is going to be carried based on the length of active tip exposure. So typically about 5 to 7 minutes before we're planning to start treatment, essentially when I'm just sort of tinkering around and screwing around with the electrodes and making sure I'm happy with everything, we'll confirm with our anesthesia team that there's complete paralysis and zero twitches, confirm that there's complete neuromuscular blockade prior to starting treatment. We'll then deliver the first 10 test pulses between each electrode pair. The generator is delivering a specific voltage, which is controlled by us, and this will generate a current within the ablation zone. And remember, our sweet spot for IRE is between 20 and 35 amps of current. So if the current produced by these test pulses is either too high or too low, we're going to adjust the voltage prior to giving the 80 treatment pulses. Remember, if the current is too low, that's more likely going to produce reversible electroporation, and it's not going to give the desired treatment effect. And if the current that's passing through is too high, it's going to be more likely to induce inadvertent thermal damage to the tissue, which is not what we want with IRE. So that sweet spot is between 20 and 35 amps. Once all the voltages between electrode pairs are finalized, we can then deliver the remaining 80 treatment pulses between each electrode pair, and the treatment itself is typically going to take somewhere between 15 and 20 minutes. So these patients, I do them all at our ambulatory surgery center. They're same-day discharge. They keep their Foley catheters for 7 to 10 days. I do insist on these patients returning to have their catheters removed for voiding trial on a day when I'm present in clinic, just because if for some reason they're unable to pass that voiding trial and they need to have a catheter replaced, I want to be aware of it, and potentially I might want to be the one to replace the catheter myself. We'll get PSAs every 3 months for the first year, and then I sort of get buy-in from patients before even doing their treatment. And I let them know everyone gets repeat MRI and repeat biopsy at the 1 year time point to confirm that there's no viable disease present either within the treatment field or outside of the treatment field. And we always reserve the right to do that for cause a little bit earlier if there's a concerning PSA trend, let's say it's 6 months after ablation. So now I'll hand the presentation over to Dr. Polascik, who will dive a little bit deeper into the technical aspects of IRE procedure and also discuss the results of the PRESERVE trial.
Thank you very much. It's my pleasure to be here today, presenting on this topic. Let me see if my slides are coming up. I'm not seeing them. Mike, you want to just take them back and I'll have you just advance
Yep,
it? Might
yep,
be easier.
absolutely, absolutely. Can you see them now?
Not yet.
Okay, should be good now.
Okay, thank you. So I have the great pleasure of working with angiodynamics really from many, many years ago when we did some of the first studies. This is at a time when the NanoKnife first came onto being, and we were working in the lab in terms of animals. Next slide, please. So I just want to give a little historical background. Next slide. Um, I'm sorry, one back. So as Dr. Rothberg mentioned, needle placement and patient selection are really the two critical factors. You got to choose the right patient, the right tumor, and then this is a precision instrument, so you want to make sure you're as accurate as you can be. And you have to rely on the probe geometry and the spacing and some of the parameters as the company has mentioned that will give you the efficacy of what you're looking for. And sometimes it comes down to just a couple millimeters. You could be off a little bit and perhaps under treat or over treat. But remember that with ultrasounds today and imaging, it's very easy to see these electrodes. You can put them exactly where you want them. You can measure them and get your treatment effect. Now, if you do put the electrodes on the capsule, you will have some treatment effect a few millimeters outside of the capsule. I know that most of the time we're treating tumors within the capsule, but there are instances where you want that energy to extend a little bit beyond. Next slide, please. Can you advance the slide, please?
Would you like one more? Or
Yeah, I'm sorry. Can you go back? So we did the first preclinical trial. This was at a time when the FDA required that we do some studies in animals first to make sure that it was safe. We did a triangulation technique. We did this study in Wisconsin. The goal was a safety study to not only have efficacy of ablation, but make sure that nothing else was injured. You can see these canine prostate were very small, 12 cc's. We did it just like we do in humans transperineally. Next slide, please. We used a triangular configuration. You know, there wasn't much space. These are really, really small prostates, and the goal was to be away from the capsule and the urethra. So you could see the measurements there. We were really down to the hundredth. And so once again, these are very accurate. Next, please. And I saw firsthand because this was essentially a ablate and resect kind of a protocol. You can see based on the pathology, you get very sharp demarcation of where your energy is deposited, and then really not even a fraction of a millimeter away, you have living tissue. So there's a lot of specificity in delivering this treatment. And we also checked the canine for erections afterwards, and I'm happy to say that 12 of 12 canine did have erections after this. There was no injury to urethra, the rectal wall, capsule, or the nerves. Next, please. So I saw firsthand the benefits and beauty of this technology. I think that the instrumentation is also very well defined. As you saw from Dr. Rothberg's video, you could easily see the electrode. You can see the tip. The needle shaft has markings on it. You have a slider where you can adjust things. It's very slim. It's 19 gauge, and there's a couple different depths, 15 and 25 centimeters. So you have a lot of control with this technology. Next, please. And I always start with whatever technology you're going to use, you have to understand your technology. So you have to understand your electrode before doing your first case. The interelectrode distance is very critical. I try to keep it within 1 to 2 centimeters. As Dr. Rothberg mentioned, you have a little wiggle room of a couple more millimeters either way, but for the most part, it's between 1 and 2 centimeters. And needles should be as parallel as you can get them. You don't want to introduce angulation because this technology works on parallel needles best. The exposure is typically 15 to 20 millimeters, although you can go up to 40 millimeters. For longer lesions, we're going to talk about later how to treat them, but you can push these forward and reapply the energy with the same needle during the same procedure. But we typically treat the apex first and then the base proximally. Next, please. It's very intuitive and easy to use. It has a nice slide handle where you can, slide these notches into pre-measured lengths. You could see on the cartoon that's being shown, this one's going to go into the 1.5 centimeter notch, and you can choose how much of an exposed needle you want. Next, please. As mentioned, I like transperineal techniques. I feel that they are the most accurate. We put these directly through the template, and I think there's a high degree of accuracy with this, particularly for the anterior tumors. So my choice with ablation is always going to be transperineal template. A lot of our biopsies that we're doing nowadays are transperineal, so you're working within the same plane. Next, please. Needle spacing is critical. As mentioned, you want it between 10 and 20 millimeters ideally. You want to avoid being too close or too far. Next, please. We typically do our measurements first. I use urinav, we do our sweep. We get everything lined up, and then we determine how long we want our needle active tip deployed. So we set all these first. We tend to use, I would say, on average, 4 needles per case, although you can use more. We'll talk about that in a minute. It's all done under ultrasound guidance. Many of these that are done nowadays come in with MRI guided mapping. So we do use the Urinav or another navigation device for additional precision. We advance deep into the target plane and then see the tips. This is all easy to switch on ultrasound, and we can switch between sagittal and transaxial. Most importantly, from a sagittal plane, you want all the needles to be approximately lined up at the same level. Next. Here's a schematic of a tumor, and we box this one in. Next, please. You saw the interface with the device. It's very user-friendly. I'm just going to point out a few features. So the top box you see, the dark gray cell indicates that the pulse parameter is where we want it to be. By default, the yellow shows that you have either above or below the default value. So you get a lot of feedback. The red and orange shows that it's showing your limits, the top limit and bottom limit. Next. And there's a lot you can do with this, not only with treatment, but you can then reconstruct on MRI with software. Next, please. And you can save these images. You can save pre-treatment, post-treatment images, etc. Next. I think we covered this. It's very important to also consider the z-axis or the depth. And as mentioned, for longer lesions, we can do a push forward. Next. So this is the push forward technique. Next. So this shows a schematic of a length of a lesion or a tumor that's maybe a little bit longer than you're used to treating, or you feel like you have to get the base a little better. So we typically start treating at the apex, and then we measure and push forward to treat at the base. That's called the push forward ablation method. Next, please. Um, Pullbacks can also be used, but we tend to use the push forward because when you do that, you're looking at untreated parenchyma, and it's easier to see that you don't see any sometimes hyperechoic treatment effect. So it is a technique that you can use, but the push forward is the preferred option. Next, please. And that's just a schematic of doing that. Next, please. A few safety considerations. In general, you should keep the electrodes at least 5 millimeters from the urethra. This was shown in the NEAT development study, and you want to keep these electrodes 5 millimeters at least from the rectal wall. Now, there's techniques to push the rectal wall further away from the treatment, such as you can put in products that can separate that plane, or you can do hydrodissection. But for the most part, the surgical principle is to keep the electrodes off the rectal wall. Next, please. This shows a high agreeability between the planned and ablated volumes. You can see those measurements here. They tend to cluster right around the mean. And some people use contrast enhanced ultrasound to look at perfusion defects, matching estimated treatment zones. You can do that, if you're interested or for research purposes, but it's not necessary. Next, please. And this is a schematic showing the effect of IRE with the electrodes placed. And on the top, you're looking at the frontal, the bottom is the transaxial, and you can see on the right, the same thing with the cartoons. There's about 5 millimeters additional treatment delivered from the tip of the needle forward. Same with back along the shaft, and then laterally, and then you get confluence between your needles, as you can see in the two schema. One is the frontal view, and the other one is the transaxial view. Next, please. Next. So this is where we get into shapes. This is, to me, interesting. So I kind of like the box configuration. I showed you a cartoon of putting the tumor in the center of the box. And by the way, as Dr. Rothberg mentioned, you have to have a good team. So we're very fortunate that we have a radiologist who's dedicated to GU radiology, and same with pathology services. But we get these marked up front with a boundary. And I tend to like the square configuration if you have a nice shape that fits in that box with a good treatment margin. I've used trapezoid, pentagon I like if you have a little tail of an extension. And this next slide, please. This is what it looks like in a cartoon form. Next. So as you can see here, you have the tumors, and then you have the red dots where the electrodes are going to grow. It all illustrates the squarezoid, the pentagon, and the rectangle. You get the probes to fit in the configuration that you like. Next, please. All right. So the total ablative volume is the consequence of ablations between the needle pairings. Next. You're going to fire them off, on each of the axis of the rectangle and then across your diagonals. We reviewed this already. Next, please. This is basically you're going to be working in the 1 to 2 centimeter range, and your interelectrode distances between 1 and 2 centimeters. Next. And this is all shown by mathematical modeling. Next. Uh, and basically, the more energy you apply, these lesions get more spherical. Next. Next. And you can see this in the cartoons. As you apply more energy, these lesions become more spherical. Next. Okay, so that's just a rundown of the technology and what you can expect from it, but understanding your patient's tumor and also the technology that you're using to ablate that is critically important. So I wanted to review the results from the PRESERVE study. This is a real, true landmark pivotal study using the NanoKnife to ablate prostate tissue for men with intermediate level risk prostate cancer. Next, please. This is the first largest prospective irreversible electroporation study using NanoKnife in the United States. Next. The objective was to assess safety and efficacy of IRE in intermediate risk prostate cancer. Next. Primary endpoint was a negative in-field biopsy at 12 months and determination of adverse event profile and severity through the first year. Next. He had 121 patients representing 17 sites. And really of interest is 14 of those 17 sites were new to IRE. Now these are physicians that are doing focal therapy. They're very good at what they do, but they were using IRE for the first time. So I think that speaks to if you understand the principles, the learning curve is quite short. These are patients with organ confined less than T2C, prostate cancer PSA less than 15, and 80% had grade group 2, and 20% had grade group 3 cancers. Next. Location, I think this is a very telling part of the story. 41% were at the apex. Now, I'm just going to make a comment that if you look at any treatment, whether it's surgery or radiation, HIFU, etc., many people fail at the apex. And we're always like, well, what can we use at the apex to better control their cancer? So I'm very happy to see that in this trial, apical lesions were treated in 41% of the patients because for me, this is a great treatment at the apex. Next. Also of note, we spoke about anterior tumors and transperineal access makes it easy and facilitates electrode placement, but also 58% of the men treated had posterior tumors. So this is a very versatile instrument that can be used throughout. Next. Okay, so what do the outcomes look like? So if you look at the PSA coming in about 5.8, and then, it starts to fall in 1 month. Most people check their PSAs at 3 months. Our lowest PSA was at 3.5 months, and you can see that the PSAs tend to stay low. Next. The overall negative infield biopsy rate at 1 year was 71%. And then there was a Delphi consensus of the experts that said, well, we saw maybe a millimeter of Gleason 6. Is that clinically significant? Most people feel it isn't because even in a study, you could treat men with a few small areas of very low grade cancer that we all agree should be monitored anyway. But when you look at the consensus definition, 84% felt that at the 12-month mark that this was effective. Next. So the median PSA nadir was 1.3, median time to PSA nadir 3.5 months, and the drop overall was about 60%. Next. Okay, functional outcomes. These are the urinary scores. So I'm a trend person, so we're just going to look at the trends. Now, if you want to look at the specifics, you see here on the left, we look at function, bother, incontinence, and total urinary domain score. But looking at the curves, there's a drop off as expected because you have things happening, swelling and all the like at 1 month. And then by 3 months, patient's essentially back to normal and is maintained for the rest of the trial period. Next. Mean IPSS scores, very similar. So initially, maybe a little bit of swelling, It may get worse a little bit by IPSS criteria at the 1 month time. And then by 3 months, you're at baseline, if not a little better, and that sustains through the 12-month time. Next. Pad-free continence. I think this is a very important outcome to men. Many men who come to see us nowadays, they know they need to treat their cancer, but they don't want the side effects. And I think this is a very, very robust number for men to maintain pad-free continence. So if you look um, overall, whether you start at 97% or 100%, depends on how you define continence going in, but by a year, 95 to 96%, no leaks. Next, please. And that's some of the highest outcomes you're going to find with any treatment. Sexual function. Again, it depends on where you come in, what your baseline is, but if you see here and on the left in all the details, talks about erectile function, intercourse satisfaction, orgasmic function, overall sexual satisfaction, desire, and total score. If you look at it, you can see the curves. Again, a little bit of a dip at 1 month, but back to baseline. And if I look at the very bottom, with the total score, the baseline men coming in was 54, and at 1 year they're at 48. They're very happy. Now, we're never going to be at 100% because some people have tumors right around the nerve bundle. So it's like the game of golf. You have to play the ball where it lies. And that's why with erections, you're never going to get 100% because men have different cancers in different locations. Next, please. Percent of patients with erection sufficient for penetration over time, same curve. 1 month, a little bit of a dip, and by 12 months, we see resumption of erections. So for all patients at 12 months, if the baseline was 81, at 12 months, it's 72%. And if you take a group that had sufficient erections for penetration going in, um, they were 84% of men had erections sufficient for penetration coming out. So again, that's very robust compared to traditional whole gland radical surgery or radical radiation therapy treatments. Next, please. Safety profiles, very important. We look at CTCAE greater than 3 events. We had 11.6% adverse event overall. And then there were 3 patients that had grade 3 or greater. There was one with abdominal pain, which resolved. There was one with a fistula, which is not clear what happened, but basically this happened several weeks. I think it was 6 weeks later at the time of another procedure he was having. And because it was a primary treatment, and he had catheter rest that resolved without any further intervention. And you're going to have a couple patients that go into retention just by the nature of what you're doing. And we had one in this series. Next. So in conclusion, PRESERVE demonstrates preservation of quality of life and functional outcomes, 96% pad-free at a year, and 84% retained erections for penetration in those who had good baseline function. Overall, men felt improved quality of life at 12 months. Next. So PRESERVE validated its endpoints in terms of safety and efficacy for the ablation of prostate tissue for intermediate risk prostate cancer patients. So it's been my great pleasure to present these results to you. Dr. Bianco.
All right, Tom and Mike, I want to congratulate you both for an excellent presentation. I think this provides a complete outline for everybody on how IRE can be used in the field of focal therapy, which is now growing. I would like to see, Mike, there's a couple of questions that were placed by the audience. Either you can take them. The first question is if some of you use standard MRI assessment schemes post-focal, and do you believe the biopsies are necessary? And I will add, when then? When would you do them? Let's start with you, Tom.
Yeah, so I wear two hats. I wear a researcher's hat, which means we have the onus on us to prove that something works. And the other hat is as a clinician. One of the benefits of this therapy is you can repeat it. So, like, why wouldn't someone not want to know if you need a repeat treatment or perhaps a new tumor has grown in an out-of-field area? So getting back, we're trying to make this standard of care, but we have to collect data. So from a research point of view, we all feel that biopsy, prom outcomes, imaging is very important. I understand from a patient's point of view, they don't even want cancer. They just can't be bothered. I understand that. But we're trying to do the right thing. And from that point of view, we have to be reasonable in collecting data and taking care of patients.
Mike.
I would agree with that. And also just to answer the first part of the question, we'll typically use standard multiparametric MRI protocols. And so that's going to include standard T2 weighted imaging, diffusion weighted, and at that 1 year time point or within that first year, if there's any suspicion of persistence or recurrence of disease, that dynamic contrast enhanced sequence is going to be very valuable in helping identify areas that might represent viable cancer that's present. But I agree with exactly what Dr. Polascik was saying. We want to build the data, and we want to be able to demonstrate that this is a viable option for treating patients, highly selected patients. And I get buy-in from them before we even do any treatment. I make sure that everybody understands that if you want to go down this pathway and do this at the 1 year time point, or perhaps sooner, there will be a repeat MRI and there will be a repeat biopsy. And so everyone commits to that. And sometimes still at the 1 year time point, people have great PSAs and negative imaging, and they'll say, "Are you sure we still have to do it?" And I say, "Yes, we do." So that's typically how it goes.
Right. The ultimate judge here is how many of these patients eventually will go into um, progress, right? Which is a composite of how many of them will be converted to more aggressive forms of therapy defined as surgery, radiation, hormonal deprivation, or if they're managed expectantly, how many of them will eventually develop non-castrate metastatic disease. However, I think that the indications for this type of treatments are growing, obviously. And one of the things that you guys I liked about, I appreciate what you guys showed today is how you're incorporating also navigation systems into helping you guys position your needles. And for the audience, we want to stress what both Dr. Polascik and Dr. Rothberg said. It's critical that those needles are in parallel, and it's critical that the tips of them are at the same depth. And I think that that's where navigation systems can provide an extra assurances. All right. The other thing that just for the audience, I mean, if you want to have put more questions on board, they're coming in. So I'm going to start. I'm going to continue to read them. And the next one is, how do you consider a good margin? Uh, how much of that is dependent on the volume of grade of the lesion? And are you using any AI tools, such as Unfold AI from Brisbane, to adjust your margin? And let's start with you, Mike, on this one.
So typically when it comes to planning treatment margins, again, having the Euronav and having the marked MR visible lesion superimposed over my real-time ultrasound is incredibly helpful. Based on the location of that marked visible lesion, I am shooting for, as best as possible, a 1 centimeter treatment margin in all dimensions around where that MR visible lesion is. And so the placement of my electrodes is done such that, again, I can measure in real time on ultrasound exactly where those electrodes are placed, and then I can extend it in either the axial or sagittal views an additional 5 millimeters beyond where the probes are located. And I can have a pretty good understanding of where the ablation zone is going to be and how far it's going to be carried out. And then I can measure from where the MR visible lesion is to where the ablation zone is going to be and confirm that I have good treatment area based on the template of electrodes that I've placed.
Terrific. Tom, just to follow on the margin question, I mean, you made a point in your talk that sometimes that electrode could be outside of the prostate because the tumor is close to the margin. I mean, it's close to the bundles or something like that, or extraprostatic. And to that end, there's two things. One, how do you measure your safety area on when you're doing that? And B, because the probe it's outside of the glandular tissue, does that decrease their effectiveness in the transmission of the electricity?
Well, just to be clear, I don't recommend that we put the needles outside the gland. But what I'm saying is
Okay,
if you put the needles close to the gland edge, you can
okay,
get a couple millimeters of treatment
outside.
effect outside. So if it's known outside the gland, then perhaps a different form of treatment is warranted. But it's just to say that you can still anticipate. Now, sometimes if I wanted the treatment to extend outside the gland, I'll do it purposefully. But certainly on the rectal surface, I wouldn't do that, right?
Right.
Mhm.
Okay, that's a great answer. When we talk about margins, people sometimes we say 1 millimeter margin, 8 millimeter margin, and people tend to think circumferentially. However, there is also a point is like most of the time the practicality of the margin is to the inside of the prostate and not really the outside because of what you guys mentioned. So I want to make that observation. Next question here is, um, well, this is a broader question. I don't know how about implementation of the IRE technology in public hospitals. I think this is something that must be referred I mean, it goes beyond the scope of this presentation today. Um, and there's another good, interesting point here. How do you guys have any experience with prostatectomies after IRE, and where would you consider are the major pitfalls? Either of
Well,
you
I
can.
guess I'll start. So,
Yeah,
you to understand the psyche of men who come in for this treatment, they don't want prostatectomy, right? I mean,
right.
they're coming in to avoid that. So we do whatever we can, and as mentioned, you can do another treatment with this, which is great. So if they're a candidate on a second attempt, that's wonderful. So we don't have a whole lot of experience. I mean, if you have an 84% chance that it works, and maybe you have another tumor that comes up and you treat again, the goal is to not have that. If you're doing proper patient selection, not to have them go on to traditional radical whole gland treatment. So we don't, I think with good patient selection, you're just not going to see that very often.
No, I agree. Doesn't happen often. For example, in our series now of close to 2,000 men treated with focal uh, therapy using cryoablation, this type of MR cryoablation, about 10% of them progress, right? They need radiation or they need surgery because they have new congratulateral tumors or for whatever reasons. Now, when you go to the surgical aspect of that procedure, sometimes you encounter more adherence in the area that you treated. In this case, I mentioned it with cryo. I am really not familiar personally with with prostatectomies after IRE. I done it after HIFU, which is if you do it after complete HIFU, it really is a very challenging procedure as the prostate is kind of like an onion. If you do it post cryo, it really is like someone who had several biopsies or may had a particular foci of inflammation in a particular spot. So, do you guys have any experience on after IRE on
Yeah,
this
so
procedure?
IRE does not, in my opinion, of course, we don't have hundreds of people that we're treating this way, but
Right.
there's not a whole lot of tissue inflammation. So I think it's minimal. And then on top of that, you're treating in a focal manner. So it's not a whole gland treatment. And oftentimes you're not even treating anywhere near the rectum. So I think it's usually not an issue. But again, if you want a non-surgical approach, you could always do radiation if you
Yeah.
needed it.
And my thinking as well, if we look at the treatment templates and we talked about the advantages of IRE, especially for anterior more anteriorly located lesions or laterally located lesions. The ablation zone, it's going to be so well defined and such a sharp cutoff and delineation between treatment and then surrounding normal tissue, and it's ideally a non-thermal mechanism of action. That vast majority of instances, that IRE ablation zone is going to be far away from posterior structures like neurovascular bundles or the rectum. And so, compared to other thermal ablation modalities or other ablation templates that might treat more of the prostate gland or might do so with heat or freezing, my suspicion is that a posterior dissection post IRA is probably not going to have as much difficulty as some of the other ablation modalities.
Mike, I don't know if you can give access to Dr. Forganti to Sri. He wanted to make a comment on this point. He has some experience as well on
Yeah,
surgery after IRE, and I think his feedback will be good.
let
Um,
me find him.
Go ahead.
uh, there
Sri?
you go. Sri, you
Oh,
there?
hey, can you guys hear me? Hold on, let me get a.
Yeah,
How is
perfect.
everybody? I have to say, I've seen a lot of talks on IRE, and that was a phenomenal overview. So, first of all, that was the graphics and the overview, and starting with the technology, that was excellent. Speaking specifically to the point, I agree. Thankfully, it doesn't come up much, but I will say a lot of it is in counseling. And I tend to tell my guys, to be realistic about it, particularly the younger guys. I say, if you're going to try this and there's significant disease and it comes back, or, the rare times that it's in field, I tell them whole gland therapy is very feasible. And certainly that's in line with the A-Way salvage guidelines. And uh, the outcomes have been reported enough that even the guidelines bodies are willing to accept that whole gland therapy after focal therapy. We have this saying that we don't burn bridges, and I think that the data is such that recovery is very similar in terms of oncologic outcomes and quality of life outcomes. And then in the handful of cases that I have taken back after IRE, there is tissue effect. It is extremely trivial for the anterior lesions. I treat posterior lesions as well, and on that side, I do what you would want to do is just be aware, right? And take the time. So it's some of your cases are going to be very quick, but if you hurry through that, you could it might be a little sticky on the apex. And so if I'm treating an apical lesion, for instance, as I'm peeling it off the apex, there's going to be some fusion to the or obliteration of the periprostatic space and whatnot. And particularly on the rectum, you're going to take your time. So often, sequencing that part of the lesion, it might be last, right? So I might take the urethra, mobilize both sides, and leave the treatment zone for last, and that I found that to be very reasonable. And then outcomes have been really un different. And then the only other statement I would have about it is this is a case where just like if were doing a salvage after radiation or a salvage after like whole gland ablation, I tend to use all my tools. I might put in, instead of a single port approach, I might use multi-port for a case like that, just so that I would have more angles and more pull in the physics. But to be honest, in terms of patient experience, it's been the same as a primary whole gland treatment.
Okay, terrific. So just to wrap up, and I want to take this last minute here to really thank Dr. Rothberg and Polascik on a terrific talk today. Their talks were fantastic, like Dr. Forganti just pointed out. And I want to build on a comment sent to us by Dr. Canfield, where he suggests that we should put together a template on the findings of radical prostatectomy, whichever technique is used after focal therapy, and compare all the energies. Certainly, the standard of prostatectomy after radiation therapy comes back out with, some, undesirable outcomes. And I'm sure that in our experience, this have been much better after focal therapy. Finally, a word for all the participants. We want to thank you very much for being part of this webinar today. Please go to the Focal Therapy Society at focaltherapy.org and register in the society, contribute to the society. One of the main goals that we have in the society is built up on the idea of the registry, which will absorb all data from multiple institutions being led by Dr. Polascik. And throughout that registry, what we really aim is to be able to analyze and do a lot of research, understanding the impacts of all these energies, IRE, cryo, HIFU, and others forthcomings, into what we are trying to do for our patients, which is deliver the best care. So without more to say, thank you, everybody. And we will make sure this webinar is accessible online through the FDS website, so you can spread the word and other people can watch them. And amazing job, gentlemen, for this presentations today. They were very, very enlightening.